Okay, guys, so here's the thing. We are going to go over EKGs, and I know that you've learned some of this before, and that's great. If you're awesome at identification, awesome. I wouldn't ignore this though, because we get more into the treatment of strips and EKGs in our class. And so, especially being exposed to the medications is also going to be in this part too. Okay. So this is overall just a reminder of where the EKG leads go. You may not always see them done exactly this way in the hospital. I'll just be honest with you. Um, Oftentimes, I know, let me see. I think you guys can see my laser pointer. Yes, I believe so. Okay. Oftentimes, you'll see the limb electrodes. You might see them actually go up here. Let's see if I can even draw like over here, and I've seen it like here and here, here and here, instead of doing it on the wrists and the ankles. Um, in fact, most EKG machines have a little picture where you can just immediately see exactly where this EKG machine wants you to go. I mean, pretty much it's not going to change the reading no matter which EKG machine you use, but I like to just go with the picture just because it gives me a good exact, this is what this EKG machine says to do. So, okay. So knowing what you're looking at whenever you are looking at a strip is important. So our you have teeny tiny boxes and you have the big boxes, right? So our teeny tiny boxes, which is these little itty bitty boxes, and let me put the laser pointer back on. These little teeny tiny boxes that you can see, those are 0.04. Okay, so the 0.04 seconds. And then one of these big boxes right here, these big boxes are zero point 0.2 seconds. So when you're looking at it, most of the time, EKG strips are typically going to be a full 6-second strip. So, and when you're like looking at an EKG printout or something along those lines, it's usually going to be a 6-second strip. And so you can guess, okay, well, if I'm looking at a 6-second strip and I see 7 QRS complexes, okay, well, then I have a heart rate of 70, right? If you didn't know exactly, like I've had it before where I've like had the EKG just printing and printing and printing, and if I needed to like look at a snapshot, you could count 30 of these boxes, the big boxes, not the little boxes, 30 of the big boxes, and that's going to equal your 6-second strip. Okay. So I used to actually teach more of the Sarah way of doing the strips, but I find simple nursing a little bit more effective only because the Sarah one worked for our stuff, but it's not going to help you as much when you get to term 4 and you do heart blocks. Whereas the simple nursing, I feel like his does help with heart blocks. So that's nice. So we look at it and we do rate and rhythm. Okay, rate and rhythm is the first. And those are the two most important parts when you're talking about what you're going to learn in term, what you've learned in term 2, and then what you're going to learn in term 3, right? So rate and rhythm, most important. P wave. So do we have a P wave? Is it present? And then this, is it married? You're probably like, what? Why is she talking about marriage? So is that P wave present and followed by a QRS complex? So what is the P wave, right? So the P wave is when we have the atria contract, right? And so when we see that, we should see followed by what? The ventricle contract. Well, that's the QRS complex. So we need to see, do we have the atria contracting and then the ventricle contracting, or S1 and S2, if you will, right? Or do we not see that, right? So those are really, really important to figure out. Things like, do we have, for example, atrial fibrillation? That would be a time that we would not have P waves, right? Do we have things like our heart blocks going on too? And this is where our PRR interval really comes into play. But also, you know, a third degree heart block, our P wave and our QRS complex are not going to be married together. They're not going to be together. They're having lots of marital problems, right? So it's important to kind of get used to looking at your P wave and then is it followed by a QRS complex? So our PR interval, is it long? Is it too long? So it should be between 0.10 and 0.20, so about 5 boxes. So we go from our P to our R to measure that. And then our QRS complex, is it present, upright, and tight? So that's what we're looking for a QRS complex. And it needs to be pretty tight, pretty small. So about 3 tiny boxes. Okay, so about 0.12 seconds. So 3 tiny boxes. Okay, so we are looking at this one. This looks like we know it's 6 seconds because we have 3 seconds and 3 seconds right there. We can count our QRS complexes. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. Yep, 9. So we have a heart rate of 90. And then what's our rhythm? So we can march this out. So we see it's about 3 boxes in between, I would say. And it's pretty consistent. It stays about 3 boxes in between. It's like 3.5 boxes in between. And it stays pretty consistent. So we have a good rhythm. We know we have a regular rhythm, right? That's what we're looking at when we look at rhythm. And then we're going to look at our P wave. And do we have a P wave followed by a QRS complex? We do, don't we? Yep, we do. And then we can look, okay, if we wanted to look at our PR interval, remember that's going to be a little bit more your heart block stuff, but we can kind of look at it. We can see, it's really hard for me to see. It's really hard to see. But, you know, we'd want to see, is it less than 0.2, right? So 5 boxes. It's hard to see, but it does look like it's about normal. And then our QRS complex, again, we want it to be less than 3 of those little boxes, the 0.12, okay, 0.12 seconds. Okay, and that looks about right. Okay. So yeah, we have a heart rate that is regular heart rate, and it is 90 seconds beats per minute. This is normal sinus rhythm. Okay, a little reminder of your cardiac conduction system and where everything goes from. So remember, we talked about our atria as our P wave, and our ventricle complex is our QRS complex. And just about how our heart rate travels from our SA node down to our AV node, goes down through the bundle of His, our right bundle branch and our left bundle branch for us to contract our ventricle. Okay. And this is just, again, another reminder. It also talks about the ventricular repolarization and depolarization. If you are a little confused with those terms, just remember your depolarization is psh, that's the contract part. Repolarization is that's the relax part, okay? So a little bit more complicated than what we just learned. However, we are not necessarily going to get into huge detail about measuring our examining our ST segment, assessing our T wave. It is important to remember things like the elevated ST segment, the peaked T's, what is that one associated with, right? Like our hyperkalemia, that kind of thing. Measuring our QT interval, that kind of thing. Okay, so this one, we already have it labeled out for us, but you know, we have a rate of 80, it says 83 beats per minute, but we wouldn't be able to get that in 60 seconds, or 60 seconds, 6 seconds, right? So we'd probably only get 80 or 8. And then looking at our P waves, it looks consistent. It does look like a regular rhythm. Our PR interval is normal. Our QRS complex is normal, and it's consistent. Okay. So this kind of gives you a better, rate, regularity, and resemblance. So that's actually what Sarayan uses, which is also a good one. It's easy and quick. I feel like just being able to simplify it this way is best. So more sinus rhythm. Again, I feel like you guys probably are pretty comfortable with this. And then you see down here, we have a 6-second strip. We have, when we're counting a rhythm, remember you count the very top of the R of your QRS. So 1, 2, 3, 4, 5, 6 is what we have, but we see these little lines. These little lines are telling us this is three seconds and then 3 seconds. So 1, 2, 3, 4, 5. So in this 6-second period, we have a rate of 5 beats, which we know times 10 is 50. So we have sinus bradycardia here, okay? So when we're talking about our sinus rhythms, remember we're talking about normal sinus rhythm and also sinus brady as well. So looking at this one, we have our rate of 110 beats per minute. This is sinus tachycardia. So we have a heart rate above 100. And yeah, we have a rate of 11 in our 6-second period and 110 beats per minute. And then again, our sinus bradycardia. This looks even scarier than our last one did. So we have our rate of 40 beats per minute with this one. And I will say those last strips, one of the things that we would really need to do if I wanted to waste your time by counting little blocks is because if you're looking at a strip and you're not entirely sure, remember, if you count the 30 big blocks, you'll be able to get to 6 seconds. Okay, so if you're ever looking at it and you're not sure exactly like how long the strip is, that's the best way to figure it out. Okay. So our atrial fibrillation, we'll get to see a picture in a second. Atrial fibrillation is when we have a chaotic rhythm, right? It's not a regular rhythm. We have no clear P waves, so you do not have P waves associated with your QRS complex. There's no P wave and then QRS, right? So that's where really being able to see, like, are they, do you have a P wave is kind of an important piece. We have no atrial contractions, loss of the atrial kick, if you will. And then an irregular ventricular response because it doesn't have that normal SA node traveling down to the AV node thing, right? And so things that it is associated with is issues with our atrial fibrosis, loss of our muscle mass. It's very common in heart disease, hypertension, heart failure, coronary artery disease, and can also be associated with genetics as well. Sorry, I saved you guys from listening to my sneeze. So we see our atrial fibrillation right here. As you can tell, there is no P wave with our married to our QRS complex. So what are some considerations for atrial fibrillation? So atrial fibrillation, a lot of times what you're going to see is the use. First of all, we want anticoagulants on board. So things like heparin, whenever we first have them come in, and we see AFib, because the concern that they can have a blood clot because your atria is not contracting, that blood can just kind of pool and sit there. Other things, though, that we might consider are things like antiarrhythmics. So amiodarone is actually also used for atrial fibrillation, although it's more common in our ventricular dysrhythmias. One of the medications that your book talks about is dronedarone. So dronedarone is a type of antiarrhythmic that we could use for atrial fibrillation. One of the things that you see most often around here is two calcium channel blockers. One is diltiazem and the other one is verapamil. So those are the two calcium channel blockers that you can use as well. Our beta blockers are sometimes used as well. There's 4 different beta blockers, so listen in your textbook, and they should be on your Google Doc as well. I don't have them right off the top of my head to be able to just list them out. I think we do have them in a future slide though. So our calcium channel blockers though are our most common. So that DILT and verapamil are the 2 most common things that you see. Other things that we could do is things like a cardiac ablation that we could also do to fix atrial fibrillation if they're stable and they're able to get it. So our risk factors for atrial fibrillation, hypertension, if they've had a stroke before, a TIA, or another thromboembolic event. Okay. Okay. So we would see if we check their apical pulse, they could be irregular. Their symptoms can depend on their ventricular rate. They might have poor perfusion. Sometimes they're asymptomatic. It really, really increases the risk of having pulmonary embolism, a venous thromboembolism, so any of the embolisms, right? It's pulmonary embolism, myocardial infarction, DVT, and cerebral vascular accident, right? So any of those scary things definitely increase their risk. And then looking at our atrial fibrillation, you can see these are 2 different EKGs. Actually, we have 2 different pieces that we're looking at right now. So one of them is our atrial fibrillation, where we have absolutely no P wave, we have an irregular rhythm. Another one is our atrial flutter, okay? So it has our sawtooth-like appearance. You can see that sawtooth-like appearance. It's also an irregular rhythm. This one is more where you have like that, the atria is kind of just going like this, right? It's kind of just going like this. Whereas the fibrillation, it's more like, I always think of it more like low, I can't get it together. It's kind of like, you know, like almost like a spasm, you know, that's how at least I think about it without actually being able to see a heart do it. So when we have those, you know, that's one of the reasons why the embolus formation is really, really a huge risk that we look at, okay? Okay, so some of the things that we can do for atrial fibrillation. So I remember I told you I'd tell you the beta blockers. I just don't remember off the top of my head. The most 2 common ones that you see are metoprolol and esmolol. And look in your book because it does go a little bit more detail about it. There is typically, I think it was 4 specific beta blockers that they could use, but those are the 2 most common. And then it also talks about that verapamil and diltiazem, and then your dronedarone is best tolerated by your patients. Amiodarone can be used, and cardiac ablation. And then to kind of show you a little bit more things that we can do, things like electrical cardioversion. So we talked a little bit about SVT in class the other day. Cardioversion was one of the things that they would do to treat that. They could also use it to treat atrial fibrillation as well, okay? And then our left ventricular appendage closure, which is using the thing like the Watchman, which has definitely been associated with preventing, not preventing, but decreasing the amount of clot formation. And then a cardiac ablation, biventricular pacing, and surgical interventions like doing a CABG, for example. So we want our patient with atrial fibrillation to definitely remain free from embolism and free from heart failure as well. obvious. Okay, so the next two things we're going to talk about are our ventricular dysrhythmias, like premature ventricular complexes. We'll talk about them just a little bit, and our supraventricular tachycardia. So ventricular dysrhythmias, we're going to talk about our PVC. This is one of the first things we're going to talk about. PVC is where you have a widened QRS complex, or premature ventricular complex. Okay, you see that PVC right there. So what's one thing that you see specifically about a PVC? Well, you don't see a P wave with it, right? Because you don't have a P wave. You have a ventricular contraction, okay? So it can be caused by things like tachycardia, like caffeine, sorry. It can be caused by caffeine. It can be caused by anxiety, for example. We look at it, and a random PVC is not necessarily anything we're going to be treating, but when you start to have more than one PVC in a row, or consistent PVCs, that's when we get concerned. When we have more than 6 in a row, that's when we can actually consider ventricular tachycardia, which is one of the life-threatening dysrhythmias that they will teach you in term 4. So if we have less than 6, it's something we're just watching, but more than 6 is considered ventricular tachycardia. Looking at our PVCs, one of the things that we talk about is what kind of PVC do we see? So 2 terms that you may have heard before: ventricular bigyminy, which is where you have PVC every other beat. So ventricular bigyminy is where you have a PVC every other beat. Ventricular trigyminy is where you have a PVC every other third beat. Okay, so you can kind of see that. Another thing that you can see for PVCs is that you have a couplet or a triplet. So you have like 2 in a row or 3 in a row, for example. So if they're spaced out, we use terms like bigyminy, trigyminy. If we have them all together, we can use terms like couplet or triplet to talk about PVCs. And PVCs, I will just tell you, it's not one of the ones that we're going to discuss about needing to know how to treat. So our supraventricular tachycardia. This is where we have a rapid beat, and you'll find, so supraventricular tachycardia is defined as being above 100 beats per minute to 280 beats per minute. If you've been taking ACLS for as long as I have, then you know that we kind of changed the definition. We used to refer to sinus tachycardia from 100 to 160, and then above 160 was supraventricular tachycardia. However, I think one of the reasons why we changed it is because that way, if you have a patient that shouldn't be sinus tach, we know that we should be treating it as opposed to just watching it happen. And I feel like when we refer to it as sinus tachycardia, and we all think, okay, sinus tachycardia can be caused by caffeine, it can be caused by exercise, it can be caused by a little bit of anemia, it's okay. I feel like we were less likely to treat. And so by changing that definition, I think it got more people to consider treating supraventricular tachycardia, even if it is about 100 if they're unstable. And that's kind of the big line is, are they, what do they look like? Are they unstable? That kind of helps us figure out what we should do for treatment, especially. So one of the medications that's associated with supraventricular tachycardia is our adenosine, okay? Adenosine is given as a 6 milligram dose, and it's administered rapidly over 1 to 3 seconds. So remember how I said there are some IV push medications that we need to know, like what's on the outside of 2 minutes, like is it 10 minutes long over here, or is it really, really fast over here? So adenosine is one of those cardiac medications that we absolutely have to give rapidly. It is followed by a 20 ml normal saline bolus, okay? It is a medication that stops the heart, resets the heart. Okay, so that's one of the main reasons why we're doing it. We're trying to get them out of the supraventricular tachycardia. A second dose of 12 milligrams may be given in a similar fashion if we still have not converted. Okay. So adenosine is our medication for supraventricular tachycardia. And actually, I'm going to pause for 1 second and review with you guys different other medications that I did not mention when we looked at the strip, because we don't really get into too much about sinus bradycardia. But sinus bradycardia would also be treated with our atropine. Okay, so our atropine was given, previously we would do 0.5, but now you'll see 1 milligram of atropine given for sinus bradycardia. And another medication that I did not specifically mention, well, I did mention, but I didn't associate with the strips. So your atrial fibrillation can also be treated with digoxin. Okay, it's not, you don't see it, again, quite as commonly, but you can end up having it treated with digoxin as well. So, of course, you want to make sure that the heart rate's above 60. That's key. Okay. I just realized that I recorded and didn't actually hit the record button. So, repeat for me, not for you. Management of SVT. So, we already talked about our adenosine. So, some of the other things that we can do to manage it. Now, these are things that they used to be done a lot more often. They're not as common anymore. Things like vagal maneuvers. Vagal maneuvers means things like having the patient bear down to decrease their heart rate. So you would tell the patient, okay, bear down, and that's a vagal maneuver. Okay, it stimulates the SA node and the AV node to kind of reset them. Another thing that's very similar effect to a vagal maneuver is doing a carotid massage, where the provider massages the carotid for about 10 seconds to kind of do the same thing as the vagal maneuver. The problem with these two is that they are temporary, and oftentimes they have rebound tachycardia afterwards, so it's not as effective. Other things that we can do is the adenosine. We already talked about that, 6 milligrams and 12 milligrams. And being able to choose between those two, adenosine is definitely going to be something that we would consider for an unstable patient. Other things that we might do is our synchronized cardioversion. We're about to see a picture of it in just a second. So our synchronized cardioversion is where we would hook them up to a defibrillator that can specifically do synchronized cardioversion, right? And we want to make sure that it is, when we say synchronize, we mean that we want, let me turn on this little thing, we want it to sync to the R part of our QRS complex, so the top peak part right here, right? And we want it to sync where you see dot, dot, dot. And then whenever it does the cardioversion, it gives them a little shock, like we're talking like 50 joules as opposed to our 200 joules that we might use to shock a patient. So that's in VTAC, VFib, that kind of thing. So our synchronized cardioversion, we want it to be synced with our QRS complex. Otherwise, we can actually make our patient go into a life-threatening dysrhythmia, like VTAC, VFib, for example. Okay, so if we're doing this, I did a critical care orientation class. And when I did it, I remember my teacher, she was like, never, ever, ever do synchronized cardioversion without sedating your patient. Okay. And I've repeated that. I've quoted her before. And then I always have those students that are like, I had to or my patient was going to die. I get it. Okay. So there are definitely times when you have to do it, but ideally they should be sedated before you're doing a synchronized cardioversion, because you are shocking the patient. That's going to hurt. So we would do this for both supraventricular tachycardia and atrial fibrillation. Okay, we want to shock that heart just to make it work just a little bit better. Okay, and this is our implantable or our cardioverter defibrillator. This actually shows us a life vest. So this isn't the implantable one specifically, but it's a life vest that is a cardioverter and defibrillator. It can be worn 24 hours a day except for when they're showering or they're bathing. They can wear this until they're stable enough to have surgical intervention. So, for example, my uncle, I think he had to wear it just recently. He had to wear it for about a month before he was able to have surgery. So before he was stable enough. Okay, so I know I did this kind of quickly. I'm trying to keep these videos short. We will go over more of this later. Just to repeat some of the medications. So we talked about digoxin, and digoxin toxicity is one of the biggest concerns with it. Remember, hypokalemia can definitely increase your risk for digoxin toxicity. We check their apical heart rate before giving it. If they do have digoxin toxicity, they would experience things like GI upset, seeing halos, spots, floaters, that kind of thing, the visual disturbances. We would give them Digibind or digoxin immune fab to help reverse it. Digoxin is used for things like atrial fibrillation, for example. Could be used in supraventricular tachycardia, but not really as often. So typically you're going to see it used with atrial fibrillation. Like I said, it's not used quite as often, except for people that have less resource, like areas that have less resources. Your ACE inhibitors is another one of those medications that's important. If you don't remember it from before, definitely look it up again. You know, I know you guys remember the angioedema because we just learned that, but also things about it is that it can be a protective factor for your potassium, okay, and it actually helps the heart work a little less hard, okay. And then moving over to our EKG stuff, we already talked about furosemide and spironolactone. Review your diuretics, but moving over to our EKG stuff. So sinus bradycardia is treated with atropine, and you'll still see it as 0.5 some places. ACLS has now changed it to 1 milligram. But atropine is one of those anticholinergic medications. So you've seen it in other things where they're like trying to decrease secretions, that kind of thing. But it is very, very effective at increasing their heart rate. Another medication that you could use is dopamine, and that totally makes sense, right? Because dopamine can help just in general increase our heart rate. And then moving on to our atrial fibrillation, the medications like diltiazem, verapamil, those are calcium channel blockers that you can see. And then our beta blockers that you can see as well. And then the dronedarone is the antiarrhythmic that you want to concentrate on. And be aware that a textbook actually even talks about amiodarone being used as well, but however, it's usually typically used with more ventricular dysrhythmias. So I would get comfortable with those medications for sure. Okay.